Our topic of discussion today is syncope. Now, syncope is a topic which can be a part of nervous system or cardiac system. A lot of systems are involved in this. So this is a multifactorial topic. And it is fairly common. You're going to see a lot of patients during your neurological rotation or your internal medicine rotation, either through the OPD or through the inpatient. Now let us start by defining what is syncope. Syncope is defined as transient loss of consciousness that is self-limiting and is acute, and it is caused by a global reduction in cerebral blood flow. Now this definition, as you can see, has certain criteria. That syncope is a transient loss of consciousness. It's not a permanent loss of consciousness, and it is an acute and self-limiting process that it occurs over a period of seconds. And for example, a person is standing, he loses his consciousness, falls to the ground, and afterwards he just gets up within a matter of seconds or within a matter of a couple of minutes. And what is the cause of this loss of consciousness? The cause is a global reduction in cerebral blood flow. Anything that can cause a reduction in the cerebral blood flow or a complete stoppage of blood flow temporarily for a matter of seconds causes syncope. As it is shown here in this diagram, that anything that causes cerebral blood flow reduction, that can cause a momentarily reduction of the blood flow to the brain, it can cause syncope. A person might be standing normally talking to you, and he can have a transient loss of consciousness, fall to the ground, and then within a matter of seconds he gets up and he's all fine. That is what is defined as syncope. There are certain conditions from which we have to differentiate syncope. Primarily, it is the differential diagnosis of syncope generally includes 4 other conditions. It is either a seizure disorder, loss of consciousness because of some seizure problem, or some ischemia, specifically the posterior circulation ischemia, the vertebrobasilar ischemia, as we call it. Hypoglycemia can cause a transient loss of consciousness, or a hypoxemia, or a reduction in the oxygen supply to the lungs or to the various parts of the body, that can also cause a transient loss of consciousness. So the differential diagnosis of transient loss of consciousness includes all these 5 conditions, and based on the way of our history and our clinical examination, we are going to differentiate syncope from the other causes of this transient loss of consciousness. Now, what are the major causes of syncope? As I told you that it is a multifactorial process, it can involve a lot of symptoms. The major cause of syncope, which is the most common cause, is called neurally mediated syncope, or it is also called reflex syncope or vasovagal syncope. Then there is orthostatic hypotension, which can lead to this transient loss of consciousness. And the third major type is the cardiac syncope, any problem with the heart that leads to this momentarily the person becoming unconscious. That is classified in cardiac syncope. The major causes or the most important cause is the neurally mediated syncope, which also includes vasovagal reflux, which is also called a person fainting in general terms, which is just said in layman terms that a person has fainted. That is because of the vasovagal syncope. We are going to discuss all of these causes in detail and what is the pathophysiology behind this in the coming slides. Now, elaborating this last slide further, let's classify syncope with the help of a flowchart. In the neurally mediated syncope, as I told you, vasovagal syncope or just normal fainting is the most common type of neurally mediated syncope. Now, this neurally mediated syncope can also be situational because of an increase in the vagal stimulation of certain systemic problem, like various systems involved, like the cardiac or the GI or the urinary system might be involved. Or it might be because of the carotid sinus hypersensitivity. We are going to discuss the carotid sinus reflex in the coming slide, and then I'm going to explain all of these in a stepwise manner. Talking about the orthostatic, the word it's self-explanatory. A person is lying supine, and then when he certainly gets up and stands, he faces some dizziness and falls to the ground or momentarily loses consciousness. That is what orthostatic syncope is, and it is related to the change in posture. Cardiac syncope is because of any cardiac abnormality. Primarily, it is either a structural heart disorder. Structural heart disorders involve majorly the valves or the myocardium, or some arrhythmic problems, some rhythm abnormalities. It might be a tachycardia problem, ventricular tachycardia, or a bradyarrhythmia like an AV node problem can cause cardiac syncope as well. The other types of syncope, which are very rare and are not very significant, they can include a person can have transient loss of consciousness when he is very acutely ill, a high-grade fever, or as I told you, some infarct in the posterior circulation. It can cause arterial occlusion, but they will have the neurological deficits as well. If someone is having a posterior supply of the brain compromised, then they will have the neurological deficits according to the area of the brain that is affected. In syncope, on the whole, generally there are no neurological deficits. There might be some pre-syncope episodes, which are the term which we use for some signs and symptoms that occur before the transient loss of consciousness. But there are no generalized neurological deficit, so that we can pinpoint to the area of the brain that is affected. And as in the definition, I told you that it is an acute and a global impairment of the cerebral blood flow. Global means that the blood flow to the whole of the brain is interrupted for a matter of seconds, and that can cause a transient loss of consciousness. Similarly, syncope can be related to some psychogenic episodes, some psychiatric disorders. They can also lead to the transient loss of consciousness. So this is the major classification of syncope. The major ones are the neurally mediated, orthostatic, and cardiac, and certain other abnormalities, as we have outlined in this flowchart. Now let's discuss about the pathophysiology. To understand the pathophysiology, it is very important to just revise the basic baroreceptor reflex. I'm sure all of you will be familiar with this. As we know that we have baroreceptors in the aortic arch and the carotid sinuses. And these are innervated by the 9th and 10th nerves, the glossopharyngeal and the vagus nerves. Whenever there is an increased stretch or a decrease in the blood flow here, that stimulates these baroreceptors. When there is an increase in the blood flow, for example, hypertension or overflow states, then these baroreceptors send the signals to the medulla here. And this nucleus ambiguous in the medulla, that stimulates via sinus node to lead to adjustment of the cardiac contractility according to the volume status. If the patient is volume overloaded, then there is an increased discharge of vagus nerve and glossopharyngeal nerve, and that leads to stimulation of the vagal nerve, and the patient will have bradycardia via SO node stimulation. There will be an increased parasympathetic stimulation and a decrease in the sympathetic stimulation. Similarly, if someone is having hemorrhage or loss of volume and there is decreased stretch of the baroreceptors at the level of the carotid sinus and the aortic arch, then the converse happens, the vagus nerve stimulation goes down, and there is an increase in the sympathetic discharge that leads to tachycardia. And also the via sympathetic ganglion, vasoconstriction occurs, venoconstriction occurs, and the body tries to restore the blood volume and cardiac contractility. And also you can see that via these connections, this medulla is also connected to the area of the hypothalamus that secretes the arginine vasopressin or the ADH hormone. And with the help of this vasopressin, it can also help in the volume restoration in very low volumes, in hypovolemic or the very low volumic states. So this is the basic baroreceptor reflex that I'm sure all of you will be familiar with. Now what happens in syncope is, especially in neurally mediated syncope, there is an exaggerated afferent limb of the baroreceptor reflex. That because of, for example, in vasovagal syncope, because of the sight of blood or certain anxious states or anxiety or because of pain, there is a hyper discharge of the vagus nerve. And this vagal nerve stimulation leads to a generalized increase in the parasympathetic stimulation and a decrease in the sympathetic stimulation. The increase in the parasympathetic stimulation leads to the bradycardia, and then because of an increase in the parasympathetic stimulation, there is a lot of acetylcholine being secreted, and that acetylcholine at the level of the vessels leads to hypotension or vasodilation, and this is also coupled by a decrease in the sympathetic stimulation. Now, one important thing to understand here is that whenever someone is fearful or painful or there is some anxious situation, initially there is a very large burst of sympathetic stimulation. So initially there is a large burst of sympathetic stimulation, and then via downward reflex, it leads to a downward movement or a control of the sympathetic stimulation. And The overall result of this is an increase in the parasympathetic stimulation, which leads to an increase in the acetylcholine being produced, and which leads to bradycardia and hypotension or vasodilation. So the bradycardia vasodilation is the generalized feature of neurally mediated or vasovagus syncope. And this is will be shown by the examples in the next coming slides, and because of which our treatment modalities are also tailored according to this. So the important thing here to remember is that the afferent limb overstimulates because of various reasons. It can be either because of a vasovagal syncope or a carotid sinus hypersensitivity, or it can either be a structural or functional problem considering the various systems, like we are going to discuss in the coming slide. So one important thing here is generally syncope is a benign process. If someone is young age, 20, 25 years old, a young man, and he has a syncope episode, and then he's all fine and there is no recurrence of the episode, or there are no high risk features, then that can be considered a benign problem. But there are certain high risk features which are especially relevant to the cardiac symptom or the cardiac system. And if these symptoms are present, then we have to evaluate the patient aggressively to look for a certain abnormality in the cardiac cause, or we may have to hospitalize the patient until the patient is well. These high-risk features are predominantly a feature of the cardiac syncope. Neurally mediated syncope is generally the most common type of syncope, and it is prevalent among the young population or the adult population. Cardiac syncope or the orthostatic hypotension, as we are going to talk about, they are generally a problem of the old age. In the orthostatic syncope, there is a generalized chronic impairment of the autonomic regulation, and the body can't quickly accommodate to the changes of the posture as in a normal young person. And in a cardiac syncope, there is some cardiac abnormality. So whenever we have syncope because of some cardiac issue, if the ECG is not fine, then we have to evaluate it further to look at that whether there is certain underlying pathology that can cause a ventricular fibrillation, or it can be life-threatening. What are the important high-risk features associated with syncope that we have to keep in mind? Let's discuss them one by one. If on evaluation of syncope we find the patient has coronary ischemia, then the patient is a high-risk patient and we have to evaluate it further. If there are features of the congestive heart failure along with the syncope, or features of the valvular disease, you have done an echocardiogram and you have found out that the patient who presented us with the syncope has some aortic stenosis maybe, or some other valvular abnormality that can cause further problems, then it is a high risk feature and we have to evaluate it further, the extent of the aortic stenosis and whether medically it is treatable, or whether we have to replace the valve. Similarly, any other structural cardiac disease, the myocardial problems, pericardial problems, history of any ventricular arrhythmia, prolongation of the QT interval greater than 500 milliseconds. This can either be an inherited problem in patients who have an inherited problem in some ion channels, or this can be related to certain antiarrhythmics or certain drugs that the patient is taken. As you know, that there are certain drugs which can cause hyperkalemia and can prolong the QT interval, and they can cause arrhythmia in a patient. And if the patient has presented to us with syncope and on ECG we have found out that there is a prolongation of the QT interval, then it is very important to evaluate this elongation, then what is causing this elongation, because that episode can occur again, and this can in the long run lead to a lethal arrhythmia in the patient as well. Similarly, if there are repetitive sinoatrial block or sinus pauses or any AV nodal problem, that is also a high risk feature. Or a persistent sinus bradycardia, someone who is not taking any beta blocker or any other medication, but their heart rate, or is not an athlete, but their heart rate is persistently low, then that is also a case to evaluate for the high risk features. Continuing on, if someone has a bi or a trifascicular block with QRS duration greater than 120 milliseconds, atrial fibrillation is also a high risk feature. It can lead to atherosclerotic problems. It can lead to further worsening of the heart failure, or it can, if the patient also has concomitant CHF. If there is some non-sustained ventricular tachycardia, or there is some family history of sudden cardiac death. As you know that in patients with hypertrophic obstructive cardiomyopathy, it is majorly a genetic problem, and these patients have a family history of sudden cardiac death at young age. Then, if someone who presents to you with syncope and he says that my father or some close relatives, I had someone who died very early and because of unexplained cardiac problem, then that should raise a red flag in your mind that I have to evaluate this patient. Patient might also be having some obstructive issues or the hypertrophic obstructive cardiomyopathy. Some pre-excitation syndromes like the Wolff-Parkinson-White syndrome, they can also lead to syncope. Or Brugada pattern on ECG. It is also a rare presentation of some abnormality, Brugada pattern, and that is also a high-risk feature. So as you have seen that all these high-risk features are concerning the cardiac system. So whenever we have syncope and it is considered because of some cardiac issue, then we have to evaluate it further and by aggressive interventions to look at the what is causing this cardiac issue. Similarly, if we have palpitation at the time of syncope or syncope at rest or during exercise, that also indicates some coronary ischemia problem. We have to look at the coronaries that this patient might be having occlusion of the coronaries, and if you can catch it in time, you might prevent a myocardial infarction in future in that patient. All right. These were some high-risk cases and they were majorly related to the cardiac system. Now let's talk about the neurally mediated syncope. Neurally mediated syncope, as I told you, is also called interchangeably, the term is used with the vasovagal reflux, and it is because of the exaggerated afferent limb discharge of the baroreceptor reflex, which leads to a hyperparasympathetic stimulation. There's a lot of acetylcholine being secreted that leads to bradycardia, and it can also overwhelm the sympathetic supply to the vessels and can cause vasodilation. So the vasodilation bradycardia syndrome, as roughly it is called, that leads to neurally mediated syncope. The patient will have a transient loss of consciousness, and then moments after the patient will get up and be fine. Now, what can cause vasovagal syncope or regular fainting, as we call it? If someone is having a provoked fear very acutely, someone has, for example, if someone is afraid of snakes, for example, and he sees a snake just like that out of nowhere, then that exaggerated or response to the baroreceptor reflex can cause transient loss of consciousness or syncope in that patient. Similarly, acute pain that is unbearable, it can also cause a syncope. Anxiety, any intense emotional episode, any intense emotion, you have heard a bad news and you were not anticipating it, and that intense emotion can disturb the baroreceptor reflex, and then after an initial sympathetic discharge, eventually it can lead to a hyperstimulation of the parasympathetic stimulation and the bradycardia vasodilation, which leads to this patient falling down or a syncope episode. Similarly, sight of blood in some people who are afraid of the blood, it can cause vasovagal syncope, and any unpleasant sight and odor in patients who are sensitive to that, it can lead to vasovagal syncope. The extent of that problem is not the major concern here. Someone might be so much afraid of blood that even with a small pint of blood, they can have loss of consciousness. Or someone, if he sees a lot of blood, for example, is involved in a road traffic accident and he sees a patient bleeding, then they can have. So the important thing is these patients are sensitized to that stimuli. So the presentation of those stimuli leads to a syncope episode in these patients. Similarly, someone who has been standing for very long in high temperatures or because of the pooling of the blood in the lower limbs, the blood supply to the heart might be affected and the baroreceptor reflex might not be working particularly fine at that time, and that can lead to a vasovagal syncope episode in that patient. Similarly, in conditions which are situational, which we call as situational reflux syncope, these are related to the various systems. And these are primarily present in the old age. The vasovagal syncope is generally can present at any age, majorly presents in the young population. The situational reflex syncope is majorly the old people or someone like that. For example, if someone who's coughing a lot and that coughing can lead to an increase in the thoracic pressure, and that leads to a transient decrease in the cardiac output, and that leads to a reduction in the blood supply to the brain. So the person who might be coughing a lot and then loses consciousness, that is called a pulmonary situation reflex syncope. Similarly, someone who's having a urogenital problem, someone who loses consciousness after maturation, which is called post-maturation syncope. GI symptoms, someone who's having a lot of, for example, constipation you can see, or some vomiting episode, or certain esophageal or colonic issue that can lead to, or that can exaggerate the syncope episode or that reflex in these patients. Similarly, cardiac problem, for example, as we just talked about, these are majorly part of the cardiac syncope problems. So this is these are the major types of the neurally mediated syncope. Carotid sinus hypersensitivity, or if we do a carotid sinus massage in some patients, that can stimulate a very large output of acetylcholine or the parasympathetic stimulation that can lead to a syncope in those patients as well. Similarly, any ocular surgery in patients or ocular massage can also increase the supply of the acetylcholine, and it can also cause a neurally mediated syncope. So these are the major types or the major causes of the neurally mediated syncope, which is the most common type of syncope in our practice. Let's talk about situational reflex syncope. What can be the various systemic problems that can lead to this problem? As I told you that in the pulmonary system, if someone is coughing excessively, then that cough can evoke a neurally mediated syncope. Similarly, if someone is playing an instrument for a long time, and that leads to that can in sensitive patients lead to a syncope episode called wind instrument players syncope. Weightlifter syncope, if someone is lifting heavy weights and is not breathing properly, then that can cause an increase in the thoracic pressure and lead to a decrease in the cardiac output and a reduction in the cerebral blood flow, and which leads to syncope. Similarly, these are the rare issues: mass trach and fainting lark. Sneeze syncope, if someone is very forcefully sneezing, then that sneeze can also lead to a pulmonary imbalance, which can eventually lead to syncope in these patients. Airway instrumentation, bronchoscopy or any other instrument can stimulate the vagus nerve in these patients, and that can lead to a syncope episode. Similarly, urogenital abnormalities like post-micturition syncope or instrumentation of the urogenital tract, prostatic massage can lead to an increase in the acetylcholine production. Anything that stimulates the parasympathetic stimulation and leads to an excess of the acetylcholine production can lead to neurally mediated syncope. This is the bottom line. In GI tract, you can see that someone who can have a syncope after swallowing, glossopharyngeal neuralgia, or esophageal stimulation that can lead to situational reflex syncope. GIT instrumentation, just like the airway instrumentation in the pulmonary system. Rectal examination can lead to pain or anxiety or fear in some patients, and that can evoke that neurally mediated or neurogenic syncope in patients. Similarly, defecation syncope, if someone who is constipated and is exerting a lot of pressure during defecation, then that can also cause syncope in these patients. Cardiac issues, basal gyrage reflex, or a cardiac outflow obstruction that leads to global impairment of the cerebral blood flow. It leads to neurally mediated syncope. So the bottom line here, as you are seeing, is that either there is an increase or a stimulation of the parasympathetic stimulation, or anything that impairs the blood flow to the brain, the vasoconstriction of the cerebral blood vessels in someone who's hyperventilating. Because when a person hyperventilates, there is a decrease in the carbon dioxide concentration, or we call that hypocarbia. That hypocarbia can lead to cerebral vasoconstriction, and that also leads to neurally mediated syncope. So these are the two basic pathophysiological mechanisms underlying this neurally mediated problem. Similarly, if someone is having a carotid sinus massage, if you stimulate the carotid sinuses, you massage it profusely, or someone has a very hypersensitive carotid sinuses, then that massage can lead to that loss of consciousness in the patient. In boxing, you must be seeing that when a boxer aims for the jaw, and if he misses the jaw and he hits the patient in this carotid sinus area, the person falls or knocks out. This is because whenever the boxer aims for that area, and if he hits the carotid sinus, that leads to an exaggerated parasympathetic stimulation, a global increase in the acetylcholine production, and that can lead to eventually bradycardia and vasodilation and the whole syncope episode. In ocular problems, that I told you, ocular pressure, pressing the eyeball, ocular examination or ocular surgery, it can also lead to neural mediated syncope. So these are the major detailed causes of situational reflex syncope, which is majorly a part of neurally mediated syncope. Apart from that, vasovagal reflex because of intense pain, anxiety, as we saw in the previous slide, sight of blood or fear, that can cause neurally mediated syncope. So these are the major causes of what we classify in the neurally mediated syncope. The pathophysiology, as I told you, at the first point, there is an exaggerated sympathetic activation, the sympathetic system. On seeing some blood, for example, the sympathetic stimulation is very much exaggerated, and then the body via reflex of in the medulla or the baroreceptor reflex leads to sympathetic withdrawal, or it tries to tone down or control this exaggerated sympathetic activity. But this sympathetic withdrawal in certain patients can lead to vasodilation in sensitive patients, and that can lead to hypertension. Similarly, if there is an exaggerated parasympathetic stimulation, exaggerated effect of the afferent limb of the baroreceptor reflex, it can lead to increased parasympathetic stimulation, which can lead to bradycardia because of sinus node, SA node reduction. And that's bradycardia vasodilation is the basic thing which we classify it as syncope. So whenever we talk about syncope, there is bradycardia or hypertension. It is also roughly called the bradycardia hypertension syndrome. So this is the pathophysiology underlying the neurally mediated syncope. Now let's look at a couple of EEGs in vasovagal syncope. What happens here is you can see that this is the normal EEG of a person who's having a vasovagal syncope, and this is drawn against a blood pressure graph and an ECG. Now, what happens here is there's gradually a decrease in the heartbeat or the cardiac, or for example, heart rate. So here you see the on ECG, the heart rate is 88. Here it has decreased to 45, and it is followed by an asystole. And in the EEG, you're seeing that there is a normal process, and then here there is a slowness of the EEG waves, but they're of a high amplitude. But the waves are of high amplitude, and this is followed by a flat line, and then again a restoration of the slow waves. This is called a slow, flat, slow response in EEG, and this response occurs at the level of whenever the patient has asystole, for example. Because of an increase in the afferent discharge of the parasympathetic stimulation, there is an increase in the parasympathetic activity, and this parasympathetic increase leads to bradycardia slowly. For example, from 88 beats, the heart rate can go to 45, and afterwards it can cause asystole as well. And similarly, the blood pressure also decreases along with that, because to counteract this bradycardia, the baroreceptor reflex is not working in these patients transiently. And this decrease in blood pressure up till this level, up to the level of, you can see 50 millimeters of mercury systolic blood pressure, is when there is transient loss of consciousness, and we can see this flat line in the EEG. And in the pre-syncope episode, we can have some dizziness, fatigue, weakness, or the patient might have some auditory problems, or there might be some myoclonic jerks in these patients. And if the patient is having a myoclonic jerks, then a person can, then you have to differentiate these, that whether this is syncope which is preceded by a myoclonic jerks, or whether this is an epileptic issue or some epilepsy problem in this patient. Then we have to do serial EEGs and other investigations to find out what is wrong. So this is an EEG of the patient. The slow, flat, slow response is the classical presentation on EEG, and it is, as you can see, preceded by the bradycardia or the asystole. Now let's draw this again and compare heart rate to the blood pressure. As you have seen that the heart rate here, from here up till this point, the heart rate and the BP are very stable. But here, because of the exaggerated parasympathetic discharge, the heart rate starts going down, and accordingly, the blood pressure also goes down. So the blood pressure falls from about 100 to about 50. And at this level, we have seen the level of the heart rate is closer to 30 or 40 beats per minute. We might see that neurally mediated syncope episode. And then afterwards, the patient restores it. When a person standing, for example, he falls down, he's flat on the ground, and the blood supply can increase, and then the patient's blood pressure slowly restores, and then his heart rate can also go up. So this is the transient or the momentary loss of consciousness which we talked about, which is self-limiting in all the causes of syncope. So this diagram very neatly shows a close relation of the blood pressure and the heart rate. This is the same diagram which we have evaluated. This is evaluated over from 60 seconds to 360 seconds over a period of 6 minutes. And this is evaluated from second minute to around 3.5 minutes. And this shows the major area of the decrease in the blood pressure, the major downward slope of the blood pressure, and then accordingly major decrease, beat by beat variation of the heart rate up till at this point where the patient will experience syncope. Now let's talk about some features of the neurally mediated syncope. Neurally mediated syncope is commonly preceded by a pre-syncope period. In this pre-syncope period, there are certain features which we are going to talk about in this slide. When a patient has cardiac syncope or syncope because of any cardiac issue, generally there are no pre-syncope episodes. They might have some syncope episode on exertion if there is a valvular abnormality, but if there is an arrhythmia, then the patient might have syncope at rest or just without any exertion. So neurally mediated syncope is these features are generally present in the neurally mediated syncope. What can be those features? Symptoms of orthostatic intolerance. If someone is standing for so long, for a long period of time, and there is intolerance to that orthostatic change, and that patient can have neurally mediated syncope afterwards. If there is a hyperstimulation of the sympathetic stimulation, as I talked about in the previous slide in the pathophysiology. So these hyperstimulation initially can lead to diaphoresis or excessive sweating, some pallor, palpitations of the heart. It can lead to nausea, vomiting. It can lead to hyperventilation. That can lead to a decrease in the carbon dioxide, and hypocarbia can cause cerebral vasoconstriction and a global impairment of the blood flow. And the patient might have some yawning, lacrimation. The pupils might be dilated. Some eye movements might be present before that syncope happens. So if someone who has recurrence of these episodes, then for example, in someone who has situational reflex syncope whenever he micturates, an old guy who after micturation he knocks out or he has a syncope episode, then whenever he starts urinating, it's in the back of his mind that now I'm going to pass out. So that patient might be nervous, or because of that there might be some sympathetic overstimulation that can cause palpitations, nausea, yawning, or the dilation of the pupils. So this is the basic thing behind it. Then there can be some grunting, moaning, snorting, and stertorous breathing, especially if it is related to the pulmonary system. Urinary incontinence can be present. Similarly, there can be a proximal and a distal myoclonus. Now, as we saw in the EEG pattern, there are jerks before and after the slow flat and the slow response. So these might be a myoclonus in the proximal muscles or the distal muscles. These are the important features of neurally mediated syncope. So now let's talk about the treatment. What are the various treatment modalities do we have? The major thing here is that, as we talked about, that generally syncope or neurally mediated syncope, in the absence of any underlying problem, absence of any underlying condition, is generally benign, and it comes and goes, and it is self-limiting. So it is very important to provide reassurance to the patient that this is a benign process and it is harmless. Similarly, if someone is having situational reflex syncope at that, or someone because of some stimulus that syncope episode comes, then we advise the patient to avoid that provocative stimuli or become hypersensitive, to avoid the hypersensitivity of this stimuli. We can advise the patient to avoid that provocative stimuli, and we reassure them that it will go away with the passage of time. If someone is low on the volume, then we can try plasma expansion with the fluid and the salt, and certain counter-intuitive measures like the isometric counter pressure maneuver of the limbs, for example, tightening of the hand grip, or for example, squatting, which can lead to an increase in the blood flow to the heart, increase in the venous return, and it can lead to restoration of the blood volume or the supply to the brain. That can also be helpful. Talking about the drugs or the pharmacotherapy, fluorocortisone is a mineralocorticoid that we know we give it to the patient, which causes vasoconstriction and can lead to restoration of the blood flow. Similarly, other vasoconstrictive agents like the alpha-1 drugs, they can also be tried. An important one here is beta blockers or the beta adrenergic receptor antagonists. Now, you might be saying that in patients, we already have an increase in the parasympathetic stimulation and bradycardia, and why are we giving beta blockers to these patients? The beta blockers are helpful in toning down that initial sympathetic surge. For example, on the seeing blood, when the patient has initial sympathetic stimulation, the beta blockers are important in toning down that increased sympathetic surge at the start of that process, which then eventually leads to an increase in the parasympathetic stimulation. So to tone down that increased sympathetic surge, we give the patients beta blockers. And that can lead to a decrease in the anxiety or the palpitations in a long term, and that can eventually might be the patient, if the patient is not having that increased surge at the beginning or the pre-syncope episodes, then that patient is very unlikely to have syncope then. So that is the rationale behind giving the beta blockers in patients with neurally mediated syncope. The use of these drugs is still under trial, and it is not 100% efficacious, but in wild variety of trials, we have seen that beta blockers have been helpful to these patients, and upon further testing, if this might be a regular treatment for the neurally mediated syncope. All right, we've talked about the major one, which is the neurally mediated. Now let's talk about the orthostatic hypotension. Orthostatic hypotension, as you know, is because hypotension or a decrease in the blood pressure when a person goes from the supine position to a standing position. So what happens here is a neurally mediated syncope, the person's autonomic system is perfectly fine, but there is a momentarily gap or a momentarily interruption of that reflex. In someone who's having orthostatic hypotension, they have a chronic impairment of the autonomic system. The autonomic system is chronically impaired, and the body does not auto-regulate or auto-adapt as quickly as in someone who is perfectly normal or in young patients. So orthostatic hypotension is generally seen in older population, someone with some abnormality of the autonomic system that leads to a delayed response in the normal physiological maneuvers to restore the blood pressure whenever someone goes from a supine to the standing position. Whenever someone goes from a supine to the standing position, there is a decrease in the venous return, and then the baroreceptors sense that decreased return and lead to a stimulation of the sympathetic stimulation, and the person does not fall. So let us now define what is orthostatic hypotension. Orthostatic hypotension is classically defined as a decrease in the systolic blood pressure of at least 20 millimeters of mercury, and the decrease in the diastolic blood pressure of at least 10 millimeters of mercury. Either both of these conditions are present or any one of these conditions are present when a person goes from supine or lying flat to a standing position. So either there is a decrease of 20 millimeters of mercury in the systolic blood pressure or a decrease of 10 millimeters of mercury in the diastolic blood pressure. We measure the blood pressure of the patient in a supine position, and then we measure their blood pressure when they are standing to find out the decrease in the systolic and the diastolic blood pressures. So again, here we are seeing here the same representation of heart rate and blood pressure. As in a normal person, if someone who goes from a supine to a standing position, there is a transient decrease in the blood pressure, which is a normal process because of pooling of blood in the legs. And in a normal person, whose autonomic reflexes are working fine, they have an increase in the heart rate or tachycardia to compensate for that blood pressure decrease. This is because of a increase in the sympathetic stimulation because of the baroreceptor reflex. But in these patients who have orthostatic hypotension, you see that the heart rate remains the same. It doesn't go up, or there is no compensatory tachycardia. And this is the major underlying issue which causes them to transiently lose consciousness, and the person might fall down. After suddenly standing, he might go down, he might fall off, or he might sit down again because of that transient loss of consciousness or that fatigue or that dizziness. Again, this is shown here with the help of a diagram. This is from the third minute from the 180 seconds to the 220 seconds. And this decrease in the blood pressure is again showing here that instead of the heart rate going up, because of the dysfunctioning of the autonomic regulation, the heart rate goes down or remains flat. And this is the major issue. which is present, the major pathophysiology of the orthostatic hypotension. Now let's look at some causes of the orthostatic hypotension. It can either be the autonomic failure, can either be primary or secondary to any other abnormality. In primary autonomic failure, certain Lewy body disease, we also term that as synuclein disease, in which there are certain inclusion bodies in the brain. The most important ones or the major ones are the Parkinson's disease, Lewy body dementia, in which we have some inclusion of these Lewy bodies, and these can lead to an autonomic failure over a long term. And these are generally evident in the older age, the Lewy body dementia or the Parkinson's, or a pure autonomic failure because of any inclusion of any protein or some abnormal folding of the protein. These are the major ones which cause the primary autonomic failure. Similarly, a multiple system atrophy along with the brain and other symptoms can lead to this autonomic failure. These were the primary problems. And now let's look at some secondary autonomic failure. Because of certain underlying disease process, the autonomic system is affected over a period of time. The most important one here is the diabetes. Someone who is chronic diabetic, and if the diabetes is not very well controlled, over a period of time, their nerves swell up because of increased sugar, and their autonomic system becomes less sensitive, and their autonomic reflexes lag behind the normal response. So in someone who's long-standing diabetes, he can have orthostatic hypotension, some amyloidosis problems. These can either be hereditary or cumulative over a period of time. Primary amyloidosis, for example, in someone who has beta-2 amyloid deposition, some senile cardiac problems in amyloid. Any amyloid deposition, amyloid is a protein, and if it deposits in the various systems, it can also cause this secondary autonomic failure. Some hereditary problems, especially the sensory and the autonomic neuropathies, which are termed as HSAN, they can also lead to the secondary autonomic failure. There's a condition called idiopathic immune-mediated autonomic neuropathy. Any immune problem or immune complex disease of which classically targets the autonomic system, it can also lead to the autonomic failure. And certain autoimmune problems can also lead to this autonomic problems. So these are generally any issue, whether this is autonomic, whether it is an immune-mediated, or because of some deposition of the proteins in amyloidosis, or because of uncontrolled blood sugar or diabetes, it can lead to a secondary autonomic failure. If it primarily involves the autonomic system and there are no certain associated diseases with it, then that is called the primary autonomic failure. Similarly, Sjogren's syndrome, as we all know, along with the other abnormalities, in long-standing Sjogren's syndrome, we can also have secondary autonomic failure. Paraneoplastic autonomic neuropathy in certain tumors, the paraneoplastic syndromes can target the nerves. It can also target the various systemic nerves as well. And HIV is also a very important and increasing cause of this secondary autonomic failure in patients with orthostatic hypotension. So this is a very exhaustive list of causes of orthostatic hypotension. The important ones here to remember are the Parkinsonism, Lewy body dementia, diabetics, amyloidosis, HIV is very common cause. So these are the important ones. Similarly, apart from the secondary autonomic failure, there might be postprandial hypotension. It is a rare problem in which someone who, after having a heavy meal, can knock down or can get unconscious if he suddenly sits up or stands after having a heavy meal, and the body is not adjusting to that increased supply of the nutrients, and the autonomic failure occurs. And this is a secondary problem as well. Drug-induced is also a very important class, specifically in drugs that target the autonomic system. For example, alpha blockers, trazocin, alpha-1 blockers, they classically have a very important side effect of orthostatic hypotension. Similarly, in patients receiving beta blockers, they can also have orthostatic hypotension, and you have to advise the patients that with the use of these drugs, after just taking the drug, you have to sit down for a while and don't start any physical activity right away, because that can lead to hypotension or loss of consciousness. Similarly, in patients who are volume depleted or volume down, for example, someone who is having diarrhea, dehydration, hemorrhage, or anything like vomiting or any hyperperspiration or diaphoresis, those who are volume depleted, they lead to a decreased blood supply to the brain, and then autonomic reflex might not act very well in these patients, and that can also lead to orthostatic hypotension. So these are the major causes of orthostatic hypotension. Now let's look at what can be the signs and symptoms of patients with orthostatic hypotension. Along with the patient falling down after changing the position, there might be some accompanied lightheadedness, dizziness, some pre-syncope. As we talked about, the patient might be feeling some weakness, fatigue, some generalized weakness, as we talked about, some fatigue. These are all the parts of the pre-syncope which we define at the area, at the time period before the syncope happens. There might be some cognitive slowing, especially in older population with the with the advancement of the age. The autonomic reflexes, their response time goes on down, and along with them, there might be some cognitive issues going on as well, especially in someone who has underlying Parkinsonism or other Lewy body diseases. There might be some leg buckling or pain. Some headache can also be a feature. These features may or may not be present in patients with orthostatic hypotension, but if these patients' symptoms are present, then you have to evaluate this patient, that whether there is some volume abnormality in these patients or certain neurological issues like Parkinsonism, or for example, if someone who's diabetic and having these symptoms, you have to evaluate their diabetic control, because they can eventually lead to orthostatic hypotension, and which can eventually lead to syncope. Similarly, visual blurring, neck pain can also be there. Certain orthostatic dyspnea or angina. Angina or orthostatic dyspnea can preclude the syncope episode. Someone who stands as having angina or a dyspnea on standing, and then sits down, and the next time he stands, he might have syncope. So these are all you can say that these are the alarm features which can raise the suspicion of someone who might have orthostatic hypotension episode or a syncope episode in the coming time. So we have to evaluate the patients according to the signs and symptoms and according to the underlying pathology. There might be supine hypertension. The patient who stands down, and whenever he is erect or standing, he has a hypotension, and if he goes down, the blood flow moves from the legs to the overall to the heart, and then patient might have hypertension on lying flat. So this supine hypertension and hypotension when a person stands, this is the classical sign of orthostatic hypotension, or some abnormality of the autonomic nervous system. The autonomic nervous system is not regulating the blood flow properly to prevent the hypo or the hypertension. These are the classic signs and symptoms of orthostatic hypotension. Now let's look at what are the treatment options. If we have a removable cause, then the number one thing is to remove that cause, either pharmacologically or non-pharmacologically. The non-pharmacological interventions involve the patient education, reassurance, again, increase in the dietary fluid and salt intake in someone who is hypovolemic or someone who is hypertensive. The pharmacological interventions can again involve fludrocortisone, it's a mineralocorticoid. Vasoconstricting agents like the alpha-1 agonists, we can give those patients. Supplementary agents can also be very important, like pyridostigmine. These are in very long-term, if someone is having a long-term issue and it is not resolved because of the non-pharmacologic or because of fludrocortisone, then that patient can be tried with a trial of pyridostigmine or yohimbine. These are very rare drugs. Or if someone is having a decrease in the ADH, then we might give that patient desmopressin or ADH product. These are the major treatment options. Erythropoietin can also be tried in someone who is very anemic and has a decrease in the RBC population. All right. Now let's talk about the third major cause of syncope, which is cardiac syncope. Cardiac syncope occurs generally in the older age, and it is either because of a structural heart disease or a arrhythmic problem. What is the pathophysiology? In an arrhythmic problem, for example, in someone who's having sinus node abnormalities like an AV block, in that patient, with the pump will be very slow, and that can lead to bradycardia. Similarly, if someone is having tachycardia, for example, ventricular or supraventricular tachycardia, then that hyperstimulation of this cardiac muscle, it leads to a pump beating very fast. But it is this pump beating fast is not very effective. There is not enough diastolic relaxation in between these pumps to effectively pool the blood. So in either case, either the pump being slow in bradycardia or the pump being too fast in tachycardia and not allowing for the heart to fill up with the blood, we are going to face a decrease in the cardiac output. So this is the major underlying pathophysiology, either in the bradycardias problems, bradycardial arrhythmias, or the tachycardia arrhythmias, that eventually they lead to a decrease in the cardiac output, and that can eventually lead to a cardiac syncope. Let's look at the two major causes. The number one, let's look at the various arrhythmias that can cause cardiac syncope. There might be a sinus node dysfunction or AV node dysfunction, supraventricular tachycardias or SVTs we call them, ventricular tachycardias, inherited channelopathies like the Brugada syndrome or the Wolff-Parkinson-White syndromes. If we talk about the cardiac structural diseases, the important ones here to highlight are the valvular diseases. For example, aortic stenosis, mitral stenosis, myocardial ischemia, certain coronary issues. There are certain obstructive and other cardiac myopathies like hypertrophic obstructive cardiomyopathy in someone who has unexplained syncope, or someone who has a relative with an unexplained sudden cardiac death. Atrial myxoma is a benign tumor of the left atrium which can have a ball valve effect at the mitral valve. Some pericardial infusions in tamponade that can hinder the heart's ability to beat and effectively receive all the blood coming to it. So these are the major structural and the arrhythmic problems that can lead to the cardiac syncope. Cardiac syncope generally comes on its own. There are very few pre-syncope periods. In someone who is having a valvular abnormality, you might face some angina or dyspnea on exertion, and afterwards the patient might have syncope. But in someone who has an arrhythmia, the patient might be just talking to you and he might be sitting and he might fall down or lose consciousness. So the pre-syncope episodes are very rare in the cardiac syncope. What can be the treatment? Cardiac pacing can be given to someone who is having heart block or AV block to maintain the cardiac output or the heart rate. Cardiac ablation can be done if someone is having an arrhythmogenic spot at the heart or a certain area of the heart is hyper or hypostimulating. We can try various antiarrhythmic drugs like amiodarone or various other types of drugs. Or there can be a cardioverter defibrillator in someone. We can implant a defibrillator in someone who has some chronic issue or chronic heart rhythm problem, so that whenever there is some arrhythmia evolving, then that chronic defibrillator or implantable defibrillator takes care of that issue. Now, we have talked about all the various causes and their treatment modalities. Now let's briefly talk about how we are going to approach a patient with syncope. What are the various differential diagnoses we have and how we are going to differentiate syncope from the other causes. The major differential diagnosis of transient loss of consciousness, or TLOS as we say, are the 5 things I talked about in the first slide. Syncope, hypoglycemia, hypoxemia, or vertebrobasilar ischemia. These are the major ones which we have to, or certain seizure disorders like epilepsy, etc. These are the ones which we have to rule out and in a stepwise manner to arrive at a diagnosis of syncope. Now, the patient has transient loss of consciousness. We have initially evaluate the patient with the help of history and physical examination. We have orthostatic blood pressure measurements. We measure the blood pressure of the patient lying flat and the patient standing. We do the ECG, we do the various labs, the various electrolytes. If we find that the loss of consciousness was because of an event other than syncope or a non-syncopal transient loss of consciousness, then we treat based on the etiology. For example, if it is because of a seizure disorder or it is because of hypoglycemia, we give the patient glucagon or sugar, or if it is because of hypoxemia, then we treat them accordingly. But if it is because of some syncope or suspected syncope, then we evaluate these on the basis of the various causes. We look at the orthostatic hypotension syncope, the neurally mediated, the cardiac, and the unexplained syncope. Let's talk about the orthostatic hypotension syncope. We look at the various risk factors. We modify the known risk factors, for example, diabetes management, the education, patient education, and pharmacotherapy like the fluorocortisone, as we talked about, is important hallmarks in this orthostatic hypotension management. If the patient is diagnosed with neurally mediated syncope, then we do a tilt test or a head-up tilt test. This is a test in which we measure the heart rate or the blood pressure of the patient in someone who's lying flat. Then we move them at various angles at 30 degree, 45, 60. These are performed under very controlled conditions to evaluate the ECG and the heart rate and the other neural EEG during these various positions, and to arrive at the diagnosis of the neurally mediated syncope. Or in someone who is hypersensitive, we can do a carotid sinus massage under controlled environment to diagnose that. If a patient has symptoms during the head up tilt test or carotid sinus massage, then that is virtually diagnostic of neurally mediated syncope. If it is diagnostic of the neurally mediated syncope, we avoid the precipitating factors. We educate the patient to avoid these factors in the future, and if necessary, we can start some pharmacotherapy. If these are not diagnostic, then we can consider then we can rule out essentially neurally mediated syncope and consider cardiac syncope or other psychogenic pseudo syncope causes as being the cause of the syncope. It can either be psychogenic because of several psychiatric abnormalities, or it can be a pseudo syncope or a one-off episode. Afterwards, then we have to look at the frequency of these syncope episodes. If they are very frequent syncopal episodes, then we have to evaluate it with the help of psychiatric evaluation or a video electroencephalography or a Holter or external loop recorder. If these episodes are infrequent or not very common, then we can have an external or an implantable loop recorder which records the syncope episodes or records the rhythm of the patient over a period of weeks. The Holter recorder is generally for 24 hours. It looks at the ECG or the rhythm of the heart over a period of 24 hours. The loop recorders are generally for a couple of weeks. The patient wears that device, and it gives us a continuous rhythm of the ECG at that record of the ECG over a period of weeks. And then we can look at the frequency of these episodes, and we can analyze that wherever these episodes happen, what is the ECG pattern of that patient. Now let's talk about the cardiac syncope, and if someone is having unexplained syncope, then we'll have to stratify the risk and use our clinical judgment. Risk stratification, as we talked about in the list in the few slides before, what are the various high-risk conditions? If the patient falls in the high-risk criteria, then the management is a bit different. And if those criteria are not met, then the patient is generally classified as a low-risk patient. In a low-risk patient, again, we look at the frequency of the syncopal episodes, whether they are frequent or infrequent. If they are frequent episodes, then we either do a Holter calculation of the rhythm or an external loop recorder. And in case of infrequent syncopal episodes, we plant a loop recorder in these patients that over a period of couple of weeks gives us a rhythm of that patient. If the patient is a high risk condition, if there is some underlying pathology, for example, heart failure or coronary ischemia, then we use the certain important investigations. We investigate the patient thoroughly with the help of an ECG, echocardiography, carotid sinus massage, or electrophysiology, the exercise testing or head up tilt testing to find out what is the major cause of this high risk symptoms and this cardiac syncope in these patients. If these evaluations are diagnostic and we find a cause of our problem, then we are going to treat the cause. And if we are not able to find any underlying pathology, then we again implant a loop recorder with the help of which we can find out the rhythm of the patient over a period of 2 weeks or 3 weeks or a period of a month, as much as we want. So this flowchart gives us a very good treatment option, or gives us a good way to evaluate step by step, diagnostically evaluate in a stepwise manner how we are going to approach a patient with syncope. As we have seen, the syncope is a very multifactorial or a multifaceted presentation. It can involve any problem from the neurological system to the pulmonary system, from the cardiac system. So stepwise approach and having the major causes in mind is very important. With the help of this flowchart, and afterwards we complete our discussion on syncope. It was a thorough lecture which discussed various types, the treatment modalities, and the diagnostic evaluation. I hope you have learned something new in this lecture. Thank you for watching sqadia.com.